Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal for covering infectious diseases and clinical microbiology. My name is Annie Joseph. I'm a clinical microbiologist at Nottingham University Hospitals in the United Kingdom and associate editor at CMI Comms. Today I'm joined by my co-host Nav Narayanan, fellow editor at CMI Comms and clinical associate professor and ID pharmacist at Rutgers University in New Jersey in the US. Hi Nav.
Hello Annie, it's great to be here again.
So today Nav and I are quite excited for the topic. We're going to be covering dengue, which is becoming increasingly relevant in more geographical settings in the context of our rapidly warming world. We're excited to welcome our two guests who are real experts in the field. We're so lucky to have them with us today. Our first is Dr. Steven Lim. Steven is a consultant in internal medicine and infectious diseases at the Raja Permaisuri Bainun Hospital in Perak, Malaysia. Steven's work spans across a broad spectrum of infectious diseases, with particular interest in HIV, multi-drug resistant infections, and neglected tropical diseases. He's a strong advocate for evidence-based medicine and is actively engaged in research, education, and national guideline development. And he's also an experienced clinical trialist and has led both investigator-initiated and industry-sponsored studies. He serves as the president of the Malaysian Society of Infection Control and Infectious Diseases and leads Malaysia's clinical working group in the Global Dengue Alliance, an international collaboration between dengue endemic countries and the Drugs for Neglected Diseases Initiative, which aims to accelerate the development of effective dengue therapeutics. Welcome, Steven, to Communicable.
Hi, Annie. Thanks for having me. Hi, Nav.
Welcome, Steven. Our second guest, another expert in the field, is André Siqueira from the nonprofit organization Drugs for Neglected Diseases Initiative, headquartered in Geneva, Switzerland, where he leads the dengue global program. André has worked in clinical research for the past 15 years, focusing on acute febrile illnesses such as malaria, dengue, and chikungunya. He's designed and conducted several observational and intervention studies for the prevention and treatment of these diseases, and was part of the team that described the risk of microcephaly in fetuses of pregnant women infected with Zika. He is also one of the principal investigators for the Butantan's dengue vaccine clinical trial and founded and coordinated the chikungunya clinical and applied research network, REPLIC. He is a member of several national and international advisory committees, including CEPI's Scientific Advisory Committee and Brazil's National Malaria and Arbovirus programs, involved in drafting the most recent versions of the clinical management guidelines for malaria, chikungunya, and dengue for the Ministry of Health. Welcome, André. It's really a pleasure to have you on Communicable.
Thank you. It's a pleasure to be with you as well, Nav, Annie, and Steven.
As our listeners know, we usually start with a get-to-know-you question. So here's the question for this week. Outside the world of science, what is a skill or hobby that you enjoy or are secretly very good at? Steve, what's your secret skill or hobby?
I really enjoy comedy, especially those comedy that involves political satire. I'm a big fan of the shows like Saturday Night Live. I'm sure it's a hit in the US. The Daily Show, especially those hosted by Jon Stewart, one of my favorite comedians. The Late Show with Stephen Colbert. I guess life is stressful sometimes. I just need some regular doses of humor and occasionally sarcasm to keep me going. A way to follow the world events from a more critical perspective.
So are we going to see a Steven Lim Netflix special soon enough? Are you,
I'm working on that, yeah.
André?
I started taking some surfing lessons, and you have to really focus on being in the sea, not being taken by the waves, but trying to ride them. It's really something that been enjoying, and you can really concentrate on that and forget everything else while they're at the sea.
Wow, I'm really impressed. So now we know our guests a little bit better. We'll get into the topic of the day and they can share their professional knowledge with us. We have quite a global listenership at Communicable, and so some of our listeners will be quite familiar with dengue, but people in non-endemic countries, like myself, will be less familiar. So Steve, could you kick things off by giving our listeners a brief refresher on dengue, the virus, the vector, the disease, get us all up to speed?
So dengue has been around for centuries. The first major documented epidemics happens in the 1700s. Dengue is caused by this dengue virus. It's actually a member of this flavivirus, which is closely related to the yellow fever virus. So it exists in 4 distinct serotypes, and I would like to thank the virologists for not giving complicated names for these serotypes. These serotypes are known as Den 1, Den 2, Den 3, and Den 4. So dengue virus are mainly spread by Aedes aegypti and also Aedes albopictus mosquitoes. One thing special about these mosquitoes is that they thrive in a very densely populated area, and especially in the tropics and also subtropical regions. If you open a medical textbook, dengue is typically recognized as a tropical disease, but emerged as a major global health threat in the 20th century, spreading beyond its traditional endemic regions in Asia as well as in the Americas to other parts of the world that you never think of, for example, in Europe. In 2019, the WHO actually identified dengue as one of the top 10 global health threats, listed alongside climate change and also antimicrobial resistance. Back to the clinical aspects of the disease, dengue is a very dynamic disease, and I still find it fascinating even after treating dengue for almost 20 years. The illness can range from a mild febrile illness to life-threatening severe disease or severe dengue. The good news is that over 95% of the patients experience only mild to moderate illness, typically with symptoms like fever, joint pains and muscle pains, and sometimes diarrhea and also nausea, vomiting. They typically recover within a week without any complications, with some symptomatic treatments. However, the other 3 to 5% unfortunate patients actually may progress to severe dengue, most often due to a significant plasma leakage leading to a hypervolemic shock. Sometimes they might develop severe bleedings and organ impairment as well. Some things are unique for dengue. The pathophysiology reflects the complex interplay between the virus and also the host immune response. The virus actually triggers the immune-mediated changes in the vascular permeability, leading to plasma leakage. Essentially, the plasma actually leaks out from the intravascular compartment into the interstitial space as well as the serosal space. If this allows to go on, it will result in hemoconcentrations, hypervolemias, and potentially hypervolemic shock. In some cases, the capillary leakage is so severe, not only plasma leaks out, but also the blood cells, the red blood cells, will also escape and giving rise to what we call occult bleeding, meaning that you won't see the bleeding with your naked eyes, but they bleed from the capillaries because of the severe plasma leakage and also the bleedings. There are 4 types of serotypes in dengue. Some of you might ask if we are infected with dengue, whether we will develop immunity against a subsequent infection. So the answer is actually yes and no. A first infection with one serotype actually provides a lifelong protection against the same serotypes. For example, if you're being infected with Den 1, your body will actually produce antibodies and memory cells to protect you against the subsequent Den 1 infections. But we know that in endemic countries like in Malaysia, in the Americas, tend to expose to more than one times of dengue infections. And sometimes it can be infected with different serotypes of dengue. So if the person is reinfected with different serotypes, the antibody that you produce will not actually protect you against that different serotypes, right? This is what we call antibody-dependent enhancement. When the antibody binds to the virus, which are from different serotypes, but it doesn't neutralize it completely. In fact, it actually enables the virus to enter immune cells in an easier way with the antibody and viral complex. It helps them to replicate in a faster rate and subsequently cause a more severe immune response and subsequently severe dengue. These antibody-dependent enhancements is important whenever we look at dengue, even at the population level, because in endemic countries like Malaysia, as I mentioned, people are often exposed to dengue multiple times. So this serotype shift may play a role, especially with outbreaks. When the predominant circulating serotype changes, many individuals are suddenly vulnerable or exposed to serotypes which are different from their previous infections. And this will set a stage where most of the patients will actually develop a severe disease because of this antibody-dependent enhancement phenomenon.
There's some complexities with dengue, especially with some of the pathophysiology. So I think that primer is quite helpful. Andre, would you be able to just take us a little bit through the epidemiology, in particular, the classical way that we think about distribution, and then what's happening now and how things are emerging and expanding?
Stephen mentioned that it was usually seen as a tropical disease, so distributed in tropical areas. We have very clear description of dengue transmission, especially in Southeast Asia, South Asia, and Latin America. The main places describing dengue outbreaks. In Southeast Asia, you usually see a more endemic transmission with high seasons and low seasons, but a constant transmission that Stephen can correct me if I'm wrong, but not varying too much between years. While in Latin America, what we've seen for the last 40 years is outbreak years followed by calmer years, 2 or 3 years interval between major outbreaks. This is really related to population dynamics, but also the virus dynamics. As Steven mentioned, we have 4 viruses, and the immunoprotection is specific for each of the serotypes. In Latin America, usually when there is a shift of the predominant serotype and enough vulnerables in the population, susceptibles, then you see the outbreaks occurring, and then they vary a lot. It has been well described that in Southeast Asia, it was seen as a pediatric disease in most intense transmission places. In Latin America, we saw a lot occurring in the adult population. A very relevant tropical area is Africa, but there is a lack of description of transmission in Africa, and it's mainly due to lack of investigation. We run seroepidemiology studies. There is, in some places, a high level of transmission, as you've seen from prior exposure to the virus. And now there is an increasing interest to understand how the disease affects the African continent. Of course, there's a major focus in malaria and not many other febrile illnesses, but dengue also contributes to that. And what we've seen in probably the last 10 years is that the dengue transmission areas are expanding. So areas that were not suffering from dengue transmission are now suffering transmission and epidemics. And this seems to be an increasing trend, as Annie mentioned in the introduction, with warming temperatures and more unstable weather, it is likely to occur even more. For example, based in Brazil, 5 years ago, we didn't hear about dengue in the southern part of Brazil, but in the last 4 years, there have been major outbreaks. And when they occur in these areas where there is a high proportion of elderly individuals, we saw a lot of elderly individuals that had no prior exposure to dengue infected and having complications. So the lethality amongst especially individuals above the age of 70 was really high, about 30% of the ones with warning signs. So it's really worrying.
Wow, 30%. That's way higher than I had even imagined. And I guess it just shows the danger of an emerging virus in a completely naive population. The impact of that is going to be very different to the endemic setting. We need to wake up and start thinking about this. You touched on diagnostics a little bit there and the kind of lack of access in some geographical regions, André. If we just talk about diagnosis for a minute, from a purely clinical setting, how can you distinguish dengue from other febrile arboviral infections like chikungunya or zika, especially in places where these are likely to co-circulate? And Steve, do you want to come in first?
Well, it's not always straightforward and sometimes can be challenging to differentiate these infections because many of these tropical infections presents as an acute febrile illness with a lot of overlapping features. So dengue often comes with high fever, severe headache, retroorbital pain, musculomalgia and arthralgia, and sometimes diarrhea and nausea and vomiting. Typically, they have thrombocytopenia as the disease progresses. While chikungunya, sometimes they come with fever, but usually present with more of severe and often prolonged joint pain. So that would be the classical features of chikungunya. While Zika, we don't usually see Zika in Malaysia, but I believe that it's underdiagnosed. Zika is usually a milder disease, and sometimes they come with some conjunctivitis and rash. If I can remember correctly, I already diagnosed and treated one Zika patient before throughout my whole career. I still believe that it's circulating around in Malaysia and in these regions. It's just that we don't actively diagnose it. So to complicate things further, in Malaysia, we also endemic for malaria, leptospirosis, scrub typhus, and I can go on and on. So in practice, we can't really rely on clinical features alone. Good diagnostics would definitely help a lot, especially for clinicians. Still, at least in my setting, the general teaching is to always suspect dengue first, always try to rule out dengue. Then we think about other possible differential diagnoses for patients who present with acute febrile illness, just purely because of the high prevalence of dengue in our regions and also the serious consequences of missing an early dengue diagnosis.
Yeah, Stephen, I guess along those lines, when it comes to diagnostic testing, you mentioned at the beginning very nicely that we've had dengue with us for a very long period of time, right? How has the diagnostic testing sort of evolved over the years? Is it completely advanced in recent years, or is it what we've been doing 50 years ago?
Over the past decades, I think the dengue diagnostics have really improved. NS1 antigen tests are now widely used for early detections. Usually within the first 5 days of illness, we should be able to detect the NS1 antigen test positive for actual dengue disease. But it also depends on how long the viremia lasts. As the disease progresses, the dengue IgM and IgG serology can help, although there's some cross-reactivity with other flavivirus or past infections or any recent infections may lead to false positives. So the result should always be interpreted in the context of history and also clinical features. In Malaysia, almost all our hospitals and clinics use rapid combo tests that includes NS1 antigen, dengue IgM and dengue IgG. Molecular tests like RT-PCR are mainly done in research labs, usually for outbreak settings and for surveillance purpose. But in routine practice, the rapid combo tests remain the backbone of our clinical diagnosis.
Andre, is there anything you want to add around the diagnostics and perhaps some of the newer antigen and biomarker tests that perhaps our listeners may not be familiar with?
Yeah, I think Steven summarized perfectly. There's been a lot of effort now trying to develop more accurate RDT, so rapid diagnostic tests, and even some work being done on near-care molecular testing. As Steven mentioned, it's very difficult to differentiate clinically between these conditions, although we will find some tables trying to differentiate the intensity of different symptoms between these arboviral infections and other conditions that are very well listed. In reality, we do need good diagnostic tests to really be sure if that person is infected or not with dengue. We have new RDTs being developed, still to demonstrate that they do perform much better compared to others, but we would like to see that coming in the next years, and the possibility of having these multiplex panels that could differentiate and give the diagnosis of these diseases. There are some in the market, but they are still very expensive and inaccessible to the general public. It would be for one test around $100 and $500, so it's quite something difficult for one individual to cover, and especially not for public health situations. And you mentioned also biomarkers. There's also an interesting element to work on. We currently don't have good biomarkers, but we are looking at biomarkers that could predict progression to severe disease and complication, because this is also a hallmark of dengue epidemics. The numbers are so high and health system get overwhelmed. The physicians and the health system have to be very well prepared to stratify and classify the patients and decide on treatment. And it takes time, it takes experience, it takes a lot of planning. And if we have a test that could identify that individual with dengue or any other febrile illnesses, then it would definitely help a lot to reduce lethality, overwhelming health systems as well.
Thank you both. It just shows some of the complications in managing these cases, even at the diagnostic stage, and understanding the risk of progression. From a management perspective, especially for listeners that have not seen a case of dengue, particularly severe dengue, what would you say are the best practices when it comes to management of a patient? And what are the things that really should be at the forefront of their mind if they do have a case that they encounter?
I said previously that dengue is a very dynamic disease, and 95% of patients actually will progress and recover without any complications. They may not need any interventions. Most of them can be managed at home without admissions to the hospitals. This 5% of patients still at risk of developing severe disease, severe dengue plus severe plasma leakage. We don't know who are these 5%. It's very different compared to, for example, pneumococcal disease, where we kind of predict that those who are going to have severe pneumococcal disease will be elderly patients with multiple comorbidities. But in dengue, it's a bit different. Based on our experience and based on our data, we have seen a lot of young patients, even though they are fit and well, some of them actually progress to severe dengue. They deteriorate, and some of them actually died. I'm an adult medicine physician. The youngest patient I've seen who died from dengue was 16 years old. And I've seen pregnant ladies die of dengue. So it's very difficult. It's very challenging for us as clinicians to decide who are the ones that we should look after when the patients have dengue. Who are the ones that we need to pay more attention? Who are the ones we need to admit the patients earlier for close monitoring? So I think picking up this 5% of patients and then keep them under close monitoring is quite a challenge. Because as of now, there's no specific antiviral for dengue. Of course, the Global Dengue Alliance, we are working on this. We are hoping that we can actually develop effective antiviral for dengue in the near future. The cornerstone of management for dengue at the moment is still good supportive care, despite dengue being a disease for around more than 200 years. And when I say supportive care, I specifically means judicious fluid management. But to do this well, I think every clinician must recognize there are 3 phases of dengue. Recognizing these phases actually helps us to guide our management in each phase of the disease. The first phase is the febrile phase. Usually they last for 2 to 3 days, sometimes up to 5 days. So during this phase, patients usually present to the healthcare facilities with symptoms like fever, muscle pain and joint pains, nausea and vomiting, and some GI symptoms, diarrhea. So at this stage, usually the management is purely symptomatic, and a lot of times they can get away with just some adequate oral intake, oral fluid to make sure that they are well hydrated. But as the disease progresses, they'll go into what we call a defervescent phase. That will be around day 4 to day 5 or day 6. And sometimes we clinicians prefer to call it a critical phase. We call it critical phase. It's just a reminder that these are the phase where even though patient may feel better because the fever subsides, the 24 to 48 hours of critical phase period is a time that the plasma leakage may occur. So usually plasma leakage won't occur during the first few days of the disease, during the febrile phase. So when the fever settles, we need to monitor closely for warning signs because we don't know who are the ones going to develop severe dengue. As I mentioned before, 5% of them. Warning signs, what it means is that those with abdominal pain, those with giddiness, persistent nausea and vomiting, diarrhea, along with rising hematocrit, or sometimes we use our ultrasound by bedside to detect any free fluid in the abdomen. So these are the patients that we need to detect early. Warning sign essentially tells us that this patient may be progressing or already having ongoing plasma leakage, leading to shock, and less commonly from bleeding or organ failures. And roughly about 1% of those who develop severe cases can be fatal. So managing fluids, again, in the presence of plasma leakage is an art, I would say. Just imagine that you are filling a leaking bucket. All of us have filled up a bucket before, but imagine that you're trying to fill up a bucket when it's leaking. The rule of the game is that you must add the water just enough to maintain the circulations, maintain the perfusions in the patients, but not too much to the extent that the fluid start to overflow to the third space. Remember that when the patient having plasma leakage, the more fluid you add onto the patients, especially when you're giving intravenous drips with crystalloids, more fluid will actually be leaked out into the third space. Too little fluid actually risks hypovolemic shock if you don't replace enough, but too much fluid also sometimes may cause fluid overload and pulmonary edema. Now, after critical phase, after these 24 to 48 hours, patient may finally go into recovery phase, usually by day 6 or day 7. These are the time that patient will remain well. If they had the plasma leakage, the capillary leakage will stop, the permeability will close up, and the fluid from the third space will start to get reabsorbed back into the intravascular compartments. Sometimes we call it reabsorption phase. Basically, during this time, it's even more important not to continuously giving IV drips so that we will make sure that all the fluid from the third space will get reabsorbed back into the intravascular compartment without any interference. So I think it's important to recognize these 3 phases: febrile phase, critical phase, and also recovery phase, because each of these phases requires a different clinical approach, especially with regards to fluid management.
Thanks, Stephen. That was really interesting. So you mentioned fatal outcome in a pregnant woman that you cared for. In pregnancy, is the course of disease generally more severe? And even if it's mild, does it have an association with adverse pregnancy outcomes?
So I guess any infections in the pregnancy, they tend to have a higher risk of complications and more severe symptoms and complications. If you think the non-pregnant individuals having to monitor the hematocrits, having to monitor their fluid status, and to decide how much to give, how much not to give is challenging. I think in the pregnant ladies, it's even more challenging because we all know that in pregnancy is a different ballgame. Everything changes. The usual monitoring, especially based on the blood parameters, like for example, hematocrits, practically not reliable because the baseline hematocrit will change, also depending on which trimester the pregnant ladies is in. So we can't rely on that to tell us, whether the patient is hemoconcentrating, having a plasma leakage, having a higher hematocrit, when the pregnant ladies actually generally will have a normal hematocrit, especially during the third trimesters. They tend to have a high risk of developing severe disease because of the physiological changes in their body as well as the difficulty for clinicians to monitor them and to make a good clinical judgment, especially with regards to fluid management during the dengue illness.
And Stephen, when it comes to other comorbidities, we have patients of chronic diseases globally. What do you keep in mind when you have a patient that you know has diabetes, cardiovascular disease, other chronic comorbidities, and how that affects the risk stratification? Are you more worried about them having severe dengue? Do you watch them more closely? Are you more likely to admit them to the hospital because of their baseline comorbidities?
Patients with all these comorbidities definitely will give them a higher risk of developing severe outcomes during their dengue illness. For me, I usually have a very low threshold to admit them, even though they come in early during the febrile phase, especially when they have uncontrolled diabetes, if they are known to have chronic kidney disease, heart disease. So these are the patients that we tend to admit earlier, even though they are well. The reason is because we know that dengue is a short disease, but when they develop acute complications like plasma leakage, it can happen immediately. And sometimes we need to catch them early, especially in the healthcare setting, rather than patient develop plasma leakage and complication at home, especially among these populations where they themselves are at risk of severe outcomes. And sometimes these patients with comorbidities, they may not deteriorate just because of the dengue infection itself. They deteriorate because of the decompensation of their underlying comorbidities. For example, patients with heart failures, sometimes they may go into decompensated heart failures because of the stress of the infections of the dengue. So if possible, we want to admit them early and then monitor them closely. And again, these populations of patients with comorbidities, especially those with heart failure, with renal disease, fluid management is even more challenging. The chance of fluid overload is actually much higher. So sometimes we do rely on blood parameters, clinical assessments. We also rely on some ultrasound imaging to look for any free fluid in the abdomen to help us to make a clinical judgment on how much fluid to give if really necessary and when to stop the fluid.
So you've mentioned about the deeffervescent or critical phase where you could potentially be falsely reassured, the temperature settles, they look well temporarily as one of the pitfalls potentially in dengue management. Have you got any other potential pitfalls that you want to highlight that you might see even amongst experienced clinicians managing dengue cases?
So I think the main pitfalls in dengue management is still always the overzealous fluid replacements. Sometimes when we manage dengue, they may appear a bit dehydrated. We tend to have a lower threshold to start IV drips. And I think we need to understand that managing fluid in dengue is different from how we manage fluid in a patient with sepsis. Because, like I said, in dengue, sometimes they have this plasma leakage, which complicates our fluid management. I've seen patients with over 5 liters of positive fluid balance after days of vigorous IV fluid resuscitations. And these are the patients that all these fluids end up in the lungs and the abdomen and resulting in acute pulmonary edemas and respiratory distress. I think we just have to be very careful not to be too overzealous about giving fluids because it's something easy to do, but also can be harmful if we don't do it correctly. Another pitfall is the failure to recognize dengue shock early or timely. Unlike septic shock, again, I'm comparing with sepsis, dengue patient may look very well and alert until they suddenly slip into hypothermic shock. I have instances where I've spoken to the patients early in the mornings, and then after 1 hour, patients collapse in the ward. So to detect this early, the dengue patient must be reviewed frequently. At least in my hospital, we make it a point to review the patient at least 3 to 4 times a day. And then also we monitor their bloods, the full blood counts, the platelet counts, the hematocrit trends. And also we monitor their vital signs, especially the pulse rate. We're looking for any tachycardias, any weak pulse, any asystotic breathing, in hope that we can intervene before they reach the point of no return. Sometimes we may overlook other causes of deteriorations. And I know that I have emphasized a lot about plasma leakage. Sometimes you may have dengue patients that remain in shock despite multiple rounds of fluid resuscitations. In that kind of situations, I think it's important to consider other possibilities. And I can list down 3 possibilities why a patient remain in shock and not improving despite us giving 3 rounds of fluid resuscitation. So number 1 is we are not giving enough fluid. Sometimes we underestimate the severity of the plasma leakage. A patient may be in decompensated shock. They may require much higher volumes of resuscitation, at least 10 to 20 cc's per kg per hours of fluid, rather than just 5 or 3 cc's of fluids. The second possibility is that maybe we are giving the wrong fluid. Usually our first line of IV drip that we are using is crystalloids. Usually we use normal saline. So I'm not sure what fluid you use, Andre, in Brazil. Do you use normal saline as well for fluid resuscitations?
Yes, we usually begin with normal saline.
Yeah. There's a lot of debate about whether to give crystalloids or colloids, especially when you're having an ongoing plasma leakage. Because colloids, in principle, they have a higher oncotic pressure. You might be able to keep the fluid in the intravascular compartment in the presence of plasma leakage. But that haven't been proven, at least in the clinical trials, to show that colloid has a better outcome. But having said that, sometimes after multiple rounds of crystalloids, if patient is not improving and you still think that it's due to plasma leakage, maybe you have to change your strategy, change your fluid to a colloids, maybe at albumins, in hope that we can keep the fluid inside the intravascular compartments. If the plasma leakage is getting more and more severe, sometimes they may start to leak out bloods. Patient may have occult bleeding. So if the patient develops occult bleeding, a normal saline or crystalloids will not help at all. In fact, it will cause more harm. So we have to be alert and detect any possibility of occult bleeding, and also to administer blood products immediately so the patient won't continue to progress into hypovolemic shock and multi-organ failures. Third possibility is that it's not fluid problem at all, because in dengue, a lot of times the main pathophysiology is plasma leakage, but we know that there's probably about 1 to 2% of patients when they develop severe dengue, it's not because of plasma leakage, but because of dengue-related organ dysfunctions. For example, myocarditis, dengue myocarditis. We have seen quite a number of dengue myocarditis causing cardiac dysfunctions, going into cardiac failures. We have seen dengue causing acute kidney injuries, liver failures, or cytokine storms like HLH that can rapidly lead to multi-organ failures. In that sense, if you encounter a patient who are not responding to fluid, maybe it's because of the organ failures rather than fluid issues. Then you have to move your strategy into organ support rather than focusing on fluids.
Thank you, Steven. That was a really wonderful overview of management. At least for me, two big takeaways. One is that it's such a small percentage that ends up needing such critical intervention. And it really tells you that the scale of incidence of dengue is so much larger than is seen by the standard observer, just because the percentage is so small that actually needs such intervention. And so clearly a major global threat that we're sort of dealing with, and it's expanding. And the second thing is we've only been talking about fluid management the entire time. I wanted to ask you, Andre, about some of the work that you have ongoing and looking to see if there's anything more than fluids, if there's actually antivirals or other drugs that we can use for treating dengue. In your work with DNDi, could you talk to us about some of the promising drug candidates, either new drug candidates or even repurposed drugs that are under investigations, and right now where they're at in terms of clinical trials?
Yeah, I think Steven lays out perfectly how we should treat dengue patients, and it's a lot based on fluid administration, and it can work really well. But what we also see is that if the health systems are not prepared, the health professionals don't know dengue, if it's not administered correctly, it can lead to a much higher rate of complications. So even in a country, you can see sometimes a 10 to 100-fold difference in mortality from dengue due to that preparation. As Steven also mentioned, many special situations such as pregnant women, elderly individuals with comorbidities, it's much more difficult to manage that than healthy adults that you can give high amount of fluid and they will tolerate well. So that's why we believe that we need to develop treatments, effective and safe treatments for dengue. The focus of us at DNDi has been to prevent progression to severe disease. For that, we are part of Dengue Alliance, which has 6 organizations from endemic countries, from Brazil, India, Thailand, and Malaysia. So Steven is a participant of the Dengue Alliance. We have a broad approach of working with repurposed drugs and also new compounds that are in the pipeline, and also exploring both antivirals and host-directed therapies, as the viremia can be very short. As for other acute viral infections, we have a very short window for intervention. So that is a challenge, as we mentioned, regarding identifying the patients and deciding on treatment. The host-directed therapies, due to the cytokine storm that leads to complication, can be very helpful even in later stages. DNDi operates in collaboration with academic partners, governments, and also industry to select good candidates that can progress to clinical trials and eventually deliver effective and safe treatments to the ones that need it the most. We know that dengue has been causing epidemics for many decades, but so far we don't have a treatment, and that's due a lot to lack of investment, as dengue was not seen as a priority for developers. We saw how quickly treatments and vaccines were developed for COVID, for example, so we believe that this can also be achieved for dengue. We also have some operational hurdles for running the trials, as we don't have effective treatments for dengue, and the rates of complications can be very high. So we want to demonstrate that the drug, it has a public health and clinical effect. If you go with deaths as outcomes or severe disease, it would lead to very large and unfeasible trials, and we don't have any clear surrogate market. So we have to interact also with regulatory bodies such as EMA, FDA, to try to agree on how we could reach that conclusion of a treatment being effective. Also operational hurdles such as we don't know where epidemics and cases will be. So you can set up very good sites for the clinical trials, but the patients don't arrive. And what we saw is a very high number of trials that have stopped earlier because they were running for a much longer period than anticipated. So it incurs very high costs, and the industry partners, they don't want to make that investment if they don't know what the results will be in a short or medium term. So this is also a challenge that in the Dengue Alliance we are trying to overcome, working with innovative ways to deliver the trials, such as mobile teams, modeling and forecasting to direct that resources so we can reach the conclusion on if a treatment works or not, and then move to the following phase. We are now in a very exciting time, and I think Steven will agree with me. So amongst the pipeline of candidates, many are now entering phase 2 and phase 3. So there is a monoclonal antibody that has shown very good antiviral effect in phase 2 trials conducted in India. So the plan is to have a global phase 3 trial beginning next year, and to evaluate how they can reduce duration and intensity of symptoms as well as progression to severe disease. This would also benefit a lot, mainly people in the higher risk groups. And we have antivirals that are now being evaluated in phase 2 trials with very promising preclinical data, as well as broad spectrum antivirals that could have an effect not only against dengue, but also against chikungunya, influenza, COVID at the same time. So that could eventually overcome the hurdle of having a very precise diagnostic test when the patient presents.
Thank you, Andre. I think it's quite interesting how some of the therapeutic trials are really dependent on some of the diagnostics or lack thereof. It's very promising to hear that there are at least things in the pipeline and at least things being studied in large clinical trials.
Yeah, it's really exciting to hear that things are coming through the pipeline. But I just wonder, how does DNDi even sort of approach prioritizing the different candidate drugs for diseases like dengue when the burden is so enormous, but the commercial incentive is so small? Are you able to give us your insight on the prioritization process, Andre?
That's a very good and challenging point. We are taking a portfolio approach. So we have a clear emergency, and we believe that we need to move fast to deliver this treatment. So we want to increase the probability of success on that. So for that, we are also exploring possibility of having the trials run as platforms, so we can incorporate the new candidates that are arising, working a lot in policy and advocacy to reinforce the need for these dengue treatments and funding for that. As we know, we need funding to run that, not only goodwill. We work a lot with the Dengue Alliance as well in having the preclinical working group that is evaluating in vivo and in vitro models the performance of both antivirals and host-directed therapies, trying to select the best candidates to go to clinical trials. So there's been trials in steroids and other host-directed therapies, and many may have failed because the evidence for the activity against the disease was not there. And we want to take this staged approach and having that evidence in place so we can move more assertively and deliver that.
Along the lines of efficiency and drug candidate selection, are trials incorporating the wide population as a whole? Is it focused on any specific vulnerable patient population? How do you sort of manage that type of heterogeneity across at-risk population and then who you actually enroll and manage in a clinical trial?
This is a really good point. We mentioned that disease expresses very different in different geographical locations. So we want to cover that by having this global trial. And also we have planned analysis to try to find out how different compounds could have a better performance in different settings. So the place with more pediatric population, we want to cover that as well if it's a place where elderly individuals are the ones most at risk. So if you can identify really well the risk of that individual to progress to severe disease, they would be very good candidates for monoclonal antibodies. We are working also on reducing the price, but currently they are still expensive. We are working closely also with groups from WHO on having ways to include these risk groups earlier in the clinical development process, such as pregnant women, children, which many times they are excluded from trials, but they are the ones that we want to target for reducing the burden of disease. So we are actively working on that, also in the preclinical testing to reduce that gap, that lead time to have evidence showing that we can use these products in these specific groups. So they are being incorporated in our clinical trial plans and discussed actively to be safe and also showing effectiveness in that group.
That's such an important point, isn't it? And I think across all areas of infectious diseases, inclusion of pregnant people and children in new therapeutic trials has traditionally been not as great as we would want. And I think it's just a really important approach when they're at the higher risk of complications in diseases such as dengue. Is there anything else either of you'd like to add on the kind of drug development side of things?
If I may add, what we are trying to develop for the dengue therapeutics is to have a drug which is easily accessible and can be administered in a population scale. In order to do that, we need a drug which is preferably oral, that patient can take the medication at home and does not necessarily need to be administered through intravenous lines. It has to be inexpensive in order for us, especially during the outbreaks, to give it to the populations that is affected in order to prevent the severe dengue. It's a challenge, but I think eventually we will prevail, hopefully in a few years' time.
Yeah, it's such a great point, Stephen. You know, even if a candidate drug is developed and is effective, if you can't get it to people who need it in a timely way and administer it to outpatients who are at risk and all of those pragmatic things, it almost starts to not matter in most healthcare settings where dengue is endemic. It just needs to have all those practical aspects of drug delivery as well as efficacy. So in the infection world, we know that prevention is better than cure. We know that. So we're going to move on to talking about dengue prevention. What have we learned about the dengue deployment vaccines? So there's two now, there's Dengvaxia and Qdenga. Have we got lessons yet about how these vaccines work in real life? Stephen, you've also already explained really nicely the importance of antibody-dependent enhancement and how that also plays into vaccine deployment. Do you want to give us your pearls of wisdom about that?
So I think the story of Dengvaxia is a sad one, but at the same time, it actually offers an important lesson, especially for vaccine researchers, health authorities, and also the public health communications. So for those who don't know, Dengvaxia was the first dengue vaccine that was rolled out in the market. And of course, the scientific community as well as the healthcare providers are very excited. If you're managing dengue for years, struggling with fluid management and all, finally we have something to prevent dengue in the community. So what happened is in Philippines, there was a mass vaccination program that was launched specifically for children. But it was later discovered that the vaccine actually increases the risk of severe dengue in individuals who have never been infected before. These are the individuals who are what we call seronegative. So basically, they have never been exposed to a dengue infections. Then they receive the Dengvaxia vaccine as a prevention. In seronegative people, this Dengvaxia actually acted, I would say, like an artificial primary infections. And it does help them to produce antibodies as what vaccine should do. But the antibodies that they produced by this Dengvaxia was insufficiently protective in these populations who are seronegative because their immune systems are not primed against true infections before. When these individuals later encounter natural dengue infections, these antibodies actually unable to neutralize the actual virus completely, and they actually facilitate the viral entry through this antibody-dependent enhancement into the immune cells. And then they facilitate the viral replications and subsequently lead to a more exaggerated immune response and subsequently severe disease with severe plasma leakage. So for this reason, Dengvaxia is now recommended only for individuals who will confirm or prior dengue infections, meaning that they need to be seropositive before they are allowed to receive this vaccine, Dengvaxia. So there are many contributing factors about this phenomenon. I think one of the contributing factors would be the vaccine design. Dengvaxia actually uses a yellow fever virus as a backbone. So while it expresses the structural proteins of all 4 dengue serotypes, because it's a yellow virus backbone, it lacks these non-structural proteins, important ones like those in the dengue virus, like NS1, which are important for the T cell activations and durable immunity. So as a result, it generates weaker and less balanced protection compared to natural dengue infections. By contrast, now we have a new vaccine called chikungunya, or also known as a TAC-003. It uses a live attenuated DEN2 virus as a backbone. So they use actual dengue virus as a backbone for the vaccines. And this will enable the vaccine to stimulate a broader and more robust immune response. So this design actually provides a good protection even among the seronegative individuals. And so far, based on the clinical trials, no safety concerns similar to Dengvaxia has been observed, meaning that those seronegative individuals who receive this chikungunya vaccine did not show that they have a high risk of developing severe dengue during the follow-ups. Up to now, they have followed up the patient up to, I think, almost 5 years. The cumulative vaccine efficacy against symptomatic dengue was about 61% over the 4.5 years for all participants, with a high efficacy among the seropositive individuals as expected. However, the efficacy against DEN4 remains uncertain purely because it has a low number of cases recorded in the clinical trials. But for Malaysia, for us, it's not much of issue, even though there are not much of conclusive results for DEN4 virus, because in countries like Malaysia, our predominant circulating serotype is a race between DEN1 and DEN2. So these 2 serotypes are the main serotypes in Malaysia and is well covered by these chikungunya vaccines.
When we think of prevention, vaccine is always at the top of the list. And so I think getting vaccines right and deploying them is as important as can be. Dengue, it's a vector-borne infection in terms of actual disease control in the population. I'm curious, especially if this differs in different parts of the world, but where do you see vector control strategies evolving, especially in the context of climate change and insecticide resistance? What do you see happening now over the world, and how are things moving forward in light of these challenges?
The expansion of dengue is closely related to urbanization. The whole world, globally, urbanization is something that we cannot stop. As new cities are built, more and more people are living at the same place in a highly dense area. I think dengue will sooner or later become prevalent in that particular area. So I think vector control with fogging, trying to eliminating the breeding sites for the mosquitoes remains important. I feel that we have done a lot with regards to vector control, and we have come to a point where there's not much more we can do to improve the outcome or the situations. Looking at the global situations with dengue epidemiologies, we need to be innovative. In some countries, like Malaysia, we also deployed Wolbachia-infected mosquitoes as a way to reduce these mosquito populations that can transmit dengue. And it's a promising tool. And currently, we are trying to scale up the Wolbachia-infected mosquitoes campaigns in several parts of our country. Genetic control methods are also being tested as well. But ultimately, I think this needs a strong community participation. I think people have to realize that dengue comes from mosquito bites. If you don't have mosquitoes, you won't have dengue. They have to take some responsibility to try to prevent mosquito breeding in their own house, in their own areas. There's so much we can do as a government authority, but I think the people themselves also have to realize that they have much more important responsibility within themselves to prevent the spread. I think we as clinicians, we need to educate patients and communicate to our communities about preventions and tell them that there's no treatment available currently. All we rely on, again, is fluids, close monitoring. Despite so many years of managing dengue, we are still fall back into the so-called supportive management. We don't have effective treatment. So they have to realize that to start taking some responsibility and reduce the burden of dengue in their own community.
Thank you, Steven. Yeah, it's such a multi-pronged approach, right? From epidemiologic surveillance and understanding the incidents in your communities and clinicians being aware of this, and even just folks in the community understanding their baseline risk. It's fascinating, innovative scientific methods to infect mosquitoes with Wolbachia to reduce viral transmission. It just speaks to funding and supporting scientific endeavors to advance innovative methods and how important that is for us.
We've covered a lot of aspects, really interesting clinical insights, Steven, from your clinical practice, your extensive clinical practice of managing dengue, and hearing from André as well, the potential drug candidates that are soon coming into clinical trials in real world settings. Then coming back to prevention and some of the challenges that are specific to dengue around antibody dependent enhancement and some of the lessons learned from vaccine deployment so far. It really is one of those multifaceted diseases of global burden of importance. So to wrap up, if you guys had to set one urgent priority for global research to address dengue in the warming world, maybe you have millions of pounds to do so, what would it be? André, do you want to go first?
That's a really good question. I think for dengue, what we need is this integrated approach in terms of how will this combination of vaccines, innovative vector control measures, and treatments be suited for different scenarios. Now we have good vaccines in the pipeline. We have the Wolbachia, as mentioned, but we still need treatment. So I would invest a lot to develop these treatments and work on ways, understand how they could reduce the burden and especially the complications that dengue is likely to cause in the following years. Unfortunately, although we have these new tools, they won't be covering all the transmission areas that we have now, and we are likely to see an expansion of the transmission areas as we've seen recently, even in Europe, in the US and others. So we will need to have good countermeasures, and treatments will be a part of that. So how we can combine that, how we can reach and deliver those solutions quickly. If we have good investment, I'm certain that we can do that in a reduced time frame.
And Steven?
The World Health Organization, they have a target by 2030 to have 0 dengue deaths. So we're talking about a global infectious disease at the global scale like dengue, and we want to achieve 0 dengue deaths. Personally, as a clinician, I think it's impossible to achieve that without effective therapeutics. If you have all the resources in the world, the top priority is to develop safe and effective therapeutics. I've talked a lot about supportive care. Supportive care does save lives. Despite the challenges, we have managed our dengue patients with supportive care in our hospitals, with hospital resources and close monitoring. But all these are not sustainable, especially when the cases are going up. We can see that dengue cases are not coming down anytime soon. I think it's the worst dengue season we have last year. I think this year, probably not by next year or so, the numbers will be doubled. So I think an oral antivirals that can be given early at the first diagnosis of dengue, much like how we do for COVID-19 previously, would be a game changer. So I would put my money on the therapeutics for dengue.
Thank you both. I think it's always helpful to hear experts relay where the priorities should be. André, Steven, I think we've really had just a fascinating discussion. I've certainly learned so much from you, and we really value your expertise. As we close, do you have any final thoughts that you'd like to share with us, with the listeners?
Thank you for hosting us. It was really a pleasure to be here discussing dengue. As a highlight, we need to work collaboratively, collaborating with these different expertise, exploring these different scenarios, And also exploring outside the field usually opens the mind to new solutions. So we keep doing the same thing we've been doing for decades. We want to innovate, so we need to open and reach people who are proposing new approaches and testing new things. I think that with innovation, we can definitely improve people's life.
For me, my message is pretty simple. I just want to say that dengue has gone global. It's no longer a tropical disease anymore. With climate change and global travels, and we know that dengue does not respect borders. It has gone as far as places like France, parts of Europe, and Mediterranean countries. It's timely that all clinicians around the world should at least know how to recognize dengue, how to diagnose, and how to have some basic knowledge on how to maneuver in terms of the fluid management and monitoring. Like what Andrea said, it's time that the whole world should come together, collaborate, implement vaccine rollouts and other strategies to move forward.
That's great. Nice messages to end on: innovation and collaboration, which I guess is true for lots of infectious diseases, isn't it? Thank you so much again to our guests, Steven Lim in Malaysia and André Siqueira in Brazil. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by me, Annie Joseph, in Nottingham, UK, and Nav Narayanan in New Jersey, US, both editors at CMI Comms, ESCMID's open access journal. It was edited and produced by Dr. Katie Hostet-Laoy and peer-reviewed by Dr. Laura Grunfeldt of the University of Tartu, Estonia. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks. And any literature we've discussed today will be found in the show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms journal. Thank you for listening and helping CMI Comms and ESCMID move the conversation in infectious diseases and clinical microbiology further along.